Hello, everyone. I hope you're doing well. This is Okiraku-Radiology. Let's take a look at another case today. First, I'll run through the images quickly. So, were you able to figure out where the lesion is in this case? If you'd like to scroll through the images yourself, just like in a clinical setting, please check out the trial linked in the description. All right, let's interpret the images together. The concerning area on today's study is right here. Near the center of the abdomen, there's a region that stands out as bright. Visceral fat normally appears dark on CT, but around the pancreas, it shows an elevated signal, looking bright. In some spots, fluid has collected and appears entirely gray. At the center of this bright area lies a horizontally oriented organ, which is the pancreas. So this image demonstrates acute pancreatitis. Now, what kind of disease is pancreatitis? Let's go over it using an illustration. As the name implies, acute pancreatitis is a condition where the pancreas suddenly becomes inflamed. Because the pancreas sits in the middle of the abdomen, some people feel abdominal pain, while others feel pain in the back. There are various causes, but excessive alcohol intake and inflammation triggered by common bile duct stones account for most cases. The pancreas secretes powerful digestive enzymes, which travel through the pancreatic duct into the digestive tract. Overconsumption of alcohol stimulates the pancreas, leading to excessive secretion of strong pancreatic juice that stresses the pancreas. And the alcohol metabolites themselves can be toxic to pancreatic tissue, resulting in pancreatitis. Additionally, if a gallstone formed in the gallbladder rolls down and lodges at the ampulla of Vater, the opening into the duodenum, it blocks bile and pancreatic juice, causing pancreatitis and cholangitis. Other causes include obstruction from pancreatic cancer, congenital anomalies like pancreatico-biliary maljunction, and autoimmune destruction of the pancreas. But these are relatively rare. The vast majority of pancreatitis arises from alcohol or gallstones. Now, let's take another look at the CT image, where the bright signal around the pancreas reflects the inflammation of pancreatitis. Inflamed areas collect fluid as exudate, and blood flow increases to deliver repair cells and immune cells like white blood cells, making the region appear bright. On CT, visceral fat looks dark, so when inflammation increases the amount of gray-appearing water, or blood, the area appears brighter. Let's compare different images of pancreatitis. Here we have a normal pancreas versus one with acute pancreatitis. In the normal pancreas, there's no accumulation of fluid around it to produce a bright appearance. The surrounding visceral fat remains dark, and the pancreas isn't enlarged. The pancreatic contour typically looks slightly granular, which you can clearly see. In contrast, the pancreatitis image shows elevated signals around the organ reflecting inflammation, and there's fluid accumulation. Inflammation causes the pancreas to swell and partially liquefy, so the granular contour becomes less distinct. Seeing them side by side makes the differences easy to appreciate. In this case, the changes aren't extremely dramatic, but in some patients, the pancreas swells more or the granular texture disappears entirely. Those findings also suggest pancreatitis. Now, let's take it up a notch. After identifying pancreatitis, the next step is to look for the underlying cause. Among the various possibilities, causes like common bile duct stones or obstruction by a tumor can often be seen on imaging, so it's worth looking for them. First, let's search for gallstones. Near the pancreatic head is a small tubular structure, the common bile duct. If a gallstone from the gallbladder rolls down and lodges here, it's called a common bile duct stone. It blocks the flow of digestive enzymes from the pancreas and triggers pancreatitis. Gallstones usually appear bright on CT, But inspection of the common bile duct shows no bright spot suggesting a stone. A few stones are radiolucent and won't show on CT, so definitive confirmation would require MRI or endoscopy. But in this CT, there's no ductal dilatation and nothing suggests obstruction. Therefore, a common bile duct stone is unlikely. Similarly, if pancreatic cancer were obstructing the duct, you'd expect to see a large tumor and dilatation of the pancreatic duct. These findings are absent, so pancreatic cancer is also unlikely. In fact, this patient has a history of alcohol dependence. Since imaging rules out common bile duct stones and pancreatic cancer, and there is a history of heavy drinking, an alcohol-induced pancreatitis is the most reasonable conclusion. Radiologically, our job is to detect pancreatitis and exclude causes like common bile duct stones or pancreatic tumors. Regarding alcohol-induced pancreatitis, you cannot see alcohol itself on imaging, but patients typically have chronic overconsumption, often leading to repeated bouts of pancreatitis, so-called chronic pancreatitis. Repeated inflammation can cause the pancreas to shrink, lose its granular structure, or become fatty and vacuous. Such changes make alcoholic pancreatitis easier to suspect. Of course, not all alcohol-related pancreatitis is chronic and mild. Many cases, like this one, present as acute dramatic inflammation. It's always a reminder to consume alcohol in moderation. Next, let's focus on the severity of pancreatitis. Pancreatitis is graded by severity, and there are CT-based criteria. Please look at this illustration. This table classifies pancreatitis based on the degree of inflammation within the pancreas and the extent of spread to surrounding tissues. First, let's evaluate the pancreas itself. In severe pancreatitis, the pancreas can become necrotic. When the pancreas becomes necrotic, blood supply ceases in that region, so contrast agent carried in the bloodstream doesn't reach it. In contrast-enhanced CT, you'll see areas that fail to enhance. Reviewing the CT for this case, there are no non-enhancing dark areas. The pancreas enhances uniformly. Therefore, there is no non-enhancing region and no pancreatic necrosis. Looking back at the classification table, the vertical axis represents pancreatic necrosis. Since no necrosis is present, the pancreas falls into the top category. Next, assess the spread of inflammation. Here's an illustration showing the anatomy around the pancreas and the peritoneal and fascial boundaries. Organs within the abdomen are enclosed by many membranes that typically aren't visible on CT, and inflammation usually remains confined within these boundaries. If it spreads beyond, the severity increases. In pancreatitis, inflammation causes these membranes to thicken so they become visible, outlining the boundaries. There's a large anterior peritoneum in front of the pancreas. If inflammation extends beyond it into the transverse colon region, that indicates anterior spread. Similarly, if it travels downward past the lower pole of the kidneys, that indicates vertical spread and a more severe process. Examining the CT, there are strong inflammatory changes around the pancreas, but no signal increase extends beyond the anterior peritoneum into the transverse colon area. If it had spread, the fat density here would brighten, but it remains dark, as normal. Now, switch to coronal images to check for inferior spread. Coronal imaging is ideal for evaluating superior-inferior extent. You can clearly see the pancreas near the midline with bright inflammatory signals around it. Regarding spread, inflammation extending below the lower poles of the kidneys would raise the grade, but on these images, the region near the lower kidney poles shows no intense inflammation. The fat remains dark. If inflammation were spreading downward, the area would brighten or collect fluid, but that isn't seen. Returning to the grading table, the horizontal axis shows the extent of spread. Since there's no extension to the transverse colon and no spread below the kidneys, this falls in the leftmost category. Thus, this case shows no pancreatic necrosis and no extensive spread beyond the fascial boundaries, placing it in the top left cell of the diagram. In other words, CT grade 1 pancreatitis. Despite dramatic findings, the CT grading suggests mild severity. Of course, this is only one imaging-based index. Actual management relies on integrating clinical presentation and lab data, so the CT grade isn't absolute. Still, it's a commonly used metric worth knowing. How is that? This is how we interpret imaging for pancreatitis. We'll cover cases with pancreatic necrosis or more severe forms in future sessions and review their imaging findings then.
Introducing Okiraku Scroll Viewer. Have you ever wanted to scroll through the scans yourself while watching imaging videos? Once you hear the answer, it sounds easy, but when you try to interpret the images on your own, it can be quite challenging. Still, if you form your own differential and then check the answer, your reading skills improve dramatically. Watching someone else scroll makes it hard to read. That's why we created Okiraku Scroll Viewer, a specialized training site for imaging interpretation. Just like in a real clinical setting, you can scroll through the images freely. It includes various cases and their answers. By scrolling yourself, making your own diagnosis, and then checking the answer before reviewing the images again, you're guaranteed to get better at reading scans. If you're interested, please jump to the link in the description and try scrolling for yourself. You can use it on both your phone and your computer. See you in the next case. Until then.